There are no financial disclosures for me. Cross-linking of collagen. In more than 10 years ago, cross-linking by means of riboflavin and UVA has been proposed as a therapeutic approach to improve the biomechanical and the biochemical properties of the cornea. Cross-linking of corneal collagen in use in ophthalmology is to arrest the progression of keratoconus in other iatrogenic keratoconus, in infectious keratitis and in bullous keratopathy. The UV light absorption of the UVA, which has a wavelength of about 300 to 400, 60% of the absorption takes place in the anterior 1/3 or the 2/3 of the cornea. UV radiation has a toxic effect on the cell viability. It can cause keratocyte and corneal endothelial cell destruction with possible lens and retinal damage. Even though cross-linking has been used worldwide, it is not yet FDA approved, and FDA approved clinical trials are underway in the US to determine its safety and efficacy. But the safety of cross-linking depends upon the endothelial damage threshold. And in human corneas, the cytotoxic keratocyte UVA irradiance is reached down to a stromal depth of 300 microns, thereby protecting the endothelium. So, with the epithelium of a 400 microns PACI can be used as a safe cutoff limit. Of late, in the last 3 years, various short-term and long-term complications have been published. That includes delayed epithelial healing with secondary infections, temporary corneal haze, permanent scars, endothelial damage, treatment failure, sterile infiltrate, and herpes reactivation. Immediately following the procedure of cross-linking, it can cause several corneal changes like transient edema, superficial nerve loss, cellular modifications, or isolated endothelial damage. But there is no significant endothelial changes were documented upon measurement of cell density and hexagonality of 1 year follow-up, no collateral damage to the unexposed limbal areas, and the epithelium regenerates completely within 4 days with the use of a bandage contact lens. Early postoperative case may be paracentral and compatible with good visual results, maybe due to the ongoing disease process and the corneal remodeling. In a recent study, which Dr. Fogler has already mentioned, a recent study of 163 cases retrospectively studied, 9% had clinically significant haze after 1 year of follow-up. The cohort of patients had low corneal thickness, advanced keratoconus at advanced age. And lacunar sign has been a positive sign of efficient cross-linking. There will be a lacunar honeycomb-like hydration pattern in the anterior stroma. This is due to the prevention of the interfibrillar cross-linking bones in the positions of the apoptotic keratocytes. How it differs from PRK haze is in the stromal depth level. Haze in PRK is usually subepithelial, whereas haze in the cross-linking extends into the anterior stroma up to the 60%. And it may be associated with the depth of the cross-linking and the amount of keratocyte loss. This study has already been mentioned. Greenstein et al. Has studied the natural history of corneal haze, which peaked at 1 month and plateaued between 1 and 3 months. And between the 3 and 6 months, the cornea begins to clear. No treatment was required except for a low-dose steroids, which was continued about 3 to 6 months. And this is the Schimfleck densitometry showing 1 month peak, the peak of corneal haze at 1 month, which naturally regressed at 12 months follow-up. The haze may be due to the backscatter and the reflected light effect, and the activated keratocytes contribute to the development of the corneal haze. But certain sight-threatening complications have also been reported of late. Various case reports like an acanthamoeba keratitis happened to be following a tap water use when the patient used tap water to wash the bandage contact lens, and poor lens hygiene led to polymicrobial keratitis. And even an HSV geographical ulcer has been reported in a patient with no prior history, and a very severe keratitis with culture-proven Pseudomonas keratitis in both cornea and the contact lens has been reported. The risk factors of infection can be the presence of epithelial defect, the contact lens wear, and the topical corticosteroid usage in the immediate postoperative period. Recently, we saw a patient, a 30-year-old, who underwent C3R elsewhere. He had an uneven C3R in the fellow eye, but this eye he developed a deep keratitis, severe keratitis at day 3 following removal of the contact lens. Dr. Gokhale has reported a diclofenac-induced acute corneal melt after cross-linking. This happened in a 19-year-old male, and the authors hypothesized that NSAIDs and anesthetic abuse can cause corneal melts if used in the presence of an epithelial defect, especially in patients with ocular surface disease. Endothelial damage, depending on the threshold, although the threshold has been of the endothelial toxicity is reported to be 0.35 millivort per centimeter square, it is almost approximately 2 times the threshold which is reaching the endothelium if the currently recommended protocol is used. But somehow endothelial damage can occur if the poor patient selection includes reduced stromal thickness or incorrect focusing or due to any faulty technique or technical problems of the UVA emitting emitter. Dr. Gokhale again reports a corneal endothelial damage in this case study. And this is a case of limbal stem cell damage following C3R. Maybe due to a faulty technique or the faulty irradiance. So recently in my practice I came across subtle complications like peripheral sterile infiltrates, which can be seen on the 3rd day of BCL removal. This can be due to an enhanced cell-mediated immunity to the staph antigens, which is represented in the high concentration in areas of the tear pooling beneath the BCL. Herpes reactivation has also been reported in literature following emotional stress, trauma, fever, and the use of topical steroids, and to the epithelial trauma following mechanical epithelial debridement. Prophylactic systemic antivirals with a prior history of, in a patient with a prior history of viral keratitis might be beneficial. Treatment failure is defined as keratoconic progression following treatment. And in the study, Dr. Fogler has already mentioned the risk factor. They found out that the risk factors of increased age more than 35 years and a high preoperative max K of above 58 diopters can lead to treatment failure. Thus, the take-home message is, since cross-linking is gradually becoming the standard technique for progressive keratoconus, the evaluation of the long-term and short-term side effects and complications is essential. And since sometimes it is used as an emergency procedure, or even if it is done on an elective or emergency, maintaining high safety standards is mandatory, and technicians should not be solely reliable for this technique. The primary complications already reported in the literature may be severe, maybe not so severe like haze or stromal hyperdensity, but the indirect origin may be due to the contact lens wear or prior LASIK surgery or pre-existing ocular surface disorder, wrong selection of the patient with a low PACI or wrong technique. Is so far reported. So surgeons with sufficient experience of corneal wound healing should be doing this procedure. Thank you.